Hello everyone, I am Dr. Zubair Ashraf and today we will be discussing another important and a common topic in pulmonology. As always, I would like to start with a clinical scenario. A 60 years old male presents in medical emergency with complaints of productive cough and high grade fever for 5 days. He is a known diabetic and taking insulin. So let's analyze this scenario. This is an elderly male around 60 years of age and he's coming to emergency. That means that the problem is acute. Only 5 days history and the history is of high grade fever and productive cough. So fever usually points to an infection and productive cough points to the site involved. So it is most likely an infection of the respiratory tract. He is a diabetic and its significance is that he is at risk of infection. On examination, his heart rate is 110 per minute, blood pressure is 85 by 60, respiratory rate of 32 per minute. All these general physical exam findings point to the severity of the infection. He is tachycardic, he is hypotensive, and he is tachypneic as well. And on auscultation of the chest, he has got coarse crackles in right lower chest. Again, this points to the site of the infection. That means that he is something going on in the chest. This is the X-ray, and if we have a close look at the X-ray, we can clearly see that there is an opacification in the right lower zone. And if we analyze this opacification, it is non-homogeneous with ill-defined borders. The borders are not very clearly defined, and the Silet sign is there, which means that you cannot clearly demarcate the right diaphragm as well as the right heart border. If you compare the right diaphragm with the left diaphragm, here you cannot see its outline. This means that there is Silet sign present, and this usually points to that the pathology is in the right lower lobe. Similarly, if the right heart border is not clearly demarkable, then that means the pathology is also in the right middle lobe. So there is a consolidation. As you can see, these air bronchogram, these linear branching shadows inside this opacification. So this is a consolidation in right middle and lower lobe, or you can use the term zones. So we will say that there is a non-homogeneous opacification in the right lower zone with air bronchogram present and Silet sign is present. So consolidation, and on the basis of the history, most probable diagnosis is pneumonia. What is pneumonia? Pneumonia, as we all know, is an infection of the lung tissue. It is characterized by symptoms and signs of an acute lower respiratory tract infection, like we saw in our scenario as well, in association with chest radiograph shadowing, not due to any other cause. So these three things are necessary. It should be an infection. The symptom and signs of lower respiratory tract infection should be there, and there should be a shadowing on chest X-ray, and then you can make the diagnosis of pneumonia. Pneumonia can be of variable presentation. Community acquired pneumonia means the pneumonia which occurs in community or within 48 hours of admission in the hospital. Hospital acquired pneumonia which occurs after 48 hours have passed since the hospital admission. And ventilator associated pneumonia is that pneumonia when a patient is started on mechanical ventilation and after passing 48 hours, they develop signs, symptoms of pneumonia, then that is called as ventilator associated pneumonia. Pneumonia that follows the aspiration of exogenous material or endogenous secretions into the lower respiratory tract. That will be called as aspiration pneumonia when a foreign body enters the respiratory tracts. It is the commonest infectious cause of the death and sixth leading cause of death in UK and USA. So even in developed countries, pneumonia causes many deaths. And the deaths or the mortality of pneumonia patient depends upon the severity. More severe patients, more ill patients are admitted in the hospital. And In UK, 5 to 10% of patients with pneumonia require ICU admissions. When a patient with pneumonia needs to be admitted in the ICU, the mortality jumps up to more than 30%. While if the patient is managed in the community settings, which means they have mild disease, then the mortality is less than 1%. There is a big difference. So can you guess what are the leading causes of death according to WHO, according to their 2019 data? As I said, pneumonia is the most common infectious cause, but the top three are the non-infectious causes: ischemic heart disease, stroke, COPD, and then on fourth there is lower respiratory infections, including pneumonia. What happens in pneumonia is that these alveoli or air sacs inside the lungs, which normally have air, they are empty inside, only they have air. They get filled up with this material, which can be pus or fluid. So when there is pus or fluid inside the alveoli, air cannot go in, and that results in hypoxia, ventilation, perfusion mismatch as well. Pneumonia can be lobar when there is the involvement of the whole lobe, or it can be bronchopneumonia when there is patchy involvement of the lobe, or even the whole lung as well. Pneumonia can be caused by variety of organisms. It can be due to bacteria. Most common are Streptococcus, Haemophilus, Moraxella catarrhalis, and Staph. Atypical pneumonia can be caused by Legionella, Mycoplasma, Chlamydia, Coxiella, and then there are viral pneumonias. We are very familiar with COVID and flu. Rhinovirus is another common virus which can cause pneumonia as well. There are certain risk factors which are present in patients having pneumonia. Some patients are at risk of aspiration. Alcoholism is also a risk factor. Again, the mechanism will be aspiration. Diabetes due to low immunity. Oral steroids again due to immunosuppression. Smokers are at again greater risk of having pneumonia. COPD patients, nursing home residents, these are all patients who are at increased risk of having pneumonia. So coming to clinical features on history, what symptoms you would expect in the history of patients having pneumonia? Like in the scenario which we discussed, there will be fever, there will be low respiratory tract symptoms which can be productive or dry cough, which can be chest pain and shortness of breath. And sometime in elderly, there can be non-specific features like lethargy, like reduced responsiveness, altered sensorium as well. And sometime there can be atypical symptoms, involvement of other organs like jaundice, nausea, vomiting, diarrhea, renal involvement, and rash as well. On examination, on general physical examination, you will find raised respiratory rate. This sign is very common and very important in children especially. They will be tachycardic due to having infection and fever, and there are localizing sign on chest examination, which can be reduced chest expansion on the affected side, which you can see or you can feel. So these finding can be observed on um, inspection and palpation. Then signs consistent with consolidation, reduce air entry with bronchial breathing, reduce percussion note or dull percussion note, increase vocal resonance, and obviously crackles. If the chest examination is normal, then the diagnosis of pneumonia is less likely. Then you should think of other causes of presentation like maybe pulmonary embolism. So after taking history, when you are suspecting pneumonia, you should go for some investigations. Included in the clinical assessment is the oxygen assessment. Then you can do a chest X-ray, which should give you the diagnosis. But sometime pneumonia can be there in the hidden areas, or it is not clearly visible on X-ray, then in those cases you can go for CT chest. Otherwise, CT chest is not mandatory for pneumonia. Similarly, in cases when you are suspecting an obstructed malignancy, mass which is causing obstruction in a bronchus, then that can also need a CT scan. Blood tests like CBC, like CRP, renal function test, these tests can help in identifying the severity of pneumonia. Then microbiological investigations, which means sputum cultures or blood cultures, can help you identify the organism involved. Procalcitonin as is quickly becoming an important test in diagnosis of bacterial infections. If procalcitonin is raised, then that points to bacterial infection. But if it is normal, then there are less chances of bacterial infection being there. So if procalcitonin is normal, you should think of viral pneumonia and stop antibiotics. ABG is again assessment of oxygenation, which again points to severity of pneumonia. X-ray is very important. X-ray is very important in the diagnosis of pneumonia. So you should be expert in picking up the findings on pneumonia, which points uh, which points to pneumonia. In this X-ray, you can see that there is an opacification in the right lower zone. You compare it on the other side, there is no opacification. This is the same X-ray which we have already discussed. And when we compare it with the normal X-ray, which you should always do, then again, it confirms that this opacification is abnormal. So this is right lower zone consolidation. And now have a look at this X-ray and compare it again with the normal X-ray. Here you can see there is opacification in the left mid and lower zone. And the left heart border, the diaphragm are not clearly visible. That means there is pneumonia in the left lower lobe. Air bronchogram is very, very important. It is a hallmark of consolidation on a chest X-ray. Consolidation is usually in pneumonia, but it can also be seen in other diseases as well. So what is air bronchogram? Air bronchogram is simply air trapped inside the bronchi when the surrounding lung is appears white due to exudation of pus and fluid in the lung parenchyma. So this is the CT showing air bronchogram, and here on the X-ray you can see bilateral air bronchogram with diffuse shadowing of both lungs. Here you can see air bronchogram upper going towards the upper zones, and here towards the lower zone, and there are branching shadows. Very important air bronchogram sign. Diagnosis of pneumonia is made on the basis of history, examination, and chest X-ray finding. There should be at least one systemic feature of sweating, fever, myalgia, and there is no other explanation for the illness. We will continue with the severity assessment in our next video. Thank you. If you have any question, you can write in the comments.